Excellencies, ladies and gentlemen, colleagues and friends, on behalf of the Community Health Coalition, CHIC, welcome to this important discussion on unlocking immunization equity through community health worker investments. It's a pleasure to see so many familiar faces. For those who haven't met with yet, I'm Riccardo Lampariello. I'm the CEO of D3. D3's mission is to expand access to high-quality essential healthcare by enabling a better decision-making. And we are an active member of CHIC. In my 25 years of work, both in private and the public sector, I rarely see an opportunity like the one that we have today to make concrete strides, concrete steps towards a more equitable work. CHIC is a coalition of community health workers, health organizations working on over 60 countries around the world. Our goal is to make professional healthcare workers the norm, being there salaried, skilled, supervised, and supplied. And we do that by changing guidelines, funding, and policy. I would like to extend my welcome to the ministries if they have arrived. Have we? Not yet, but we were supposed to have the Minister of Uganda, the Minister of Burkina Faso, and then representation from Kenya, that is here, Tanzania. And I would also like to welcome esteemed colleagues from other organizations like the World Health Organization, World Economic Forum, Gavi, Global Fund, and Africa CDCs, among others. At CHIC, we strongly believe that the community health workers should be in the room each time we talk about community health. And so I also very proud to welcome the community health workers that are in the room, and you'll have the pleasure to hear from them. In the next hour and a half, we'll highlight the community level gaps and challenges that affect zero-dose under-immunized children. Together, we'll define and reaffirm the vital role of community health workers in promoting immunization equity, increasing immunization demand and coverage, and reaching global health goals. We also identify opportunities to support countries to develop and scale models to strengthening last-mile immunization systems. Now I would like to share some reflections with you. So many years ago, I worked at Gavi. I was crunching numbers, estimating, calculating doses for the global demand of vaccines. And so I would look at coverage for measles, DPT3, HPV, and then by looking at those figures, little by little, I was actually realizing that those children missing actually one vaccine were also likely to miss other vaccines. At that time, we were talking about a fully immunized child. Then they became zero-dose children. Today, we have 20 vaccines for life-threatening diseases, and millions of children every year don't get even one dose of those vaccines. 1 in 7, according to UNICEF. And why? Because they are not reached. This is absolutely not acceptable. Years later, I could fully appreciate the role of community health workers, playing the role they play in reaching the unreached. Community health workers are trusted agents from the community. They often serve as the first, if not the only, point of care for many areas with limited access or not without access to healthcare. They're uniquely positioned to reach the zero-dose children. Equipped with the digital tools, community health workers can monitor the status of vaccination and support the full course of vaccination. Then, through data analysis, we can uncover gaps in the immunization response, and we can provide timely and tailored corrective actions. But the role of community health workers, of course, goes beyond vaccination. They support maternal and child health, they tackle malnutrition, epidemics, and now also the non-communicable diseases. I see this every single day in my organization in Tanzania, Zanzibar, Malawi, and Zambia. And any of the CHIC member organizations says in the countries, over 60 countries in the world, they see how community health workers can really reach the unreached, save lives, and avoid unnecessary suffering. We will hear some stories in a few seconds. D3 also has the privilege to support the Zanzibar government to nationally scale the community health program. And the government announced only a few months ago the professionalizations of community health workers, from volunteers to workers, being salaried, skilled, supplied, and supervised, a course that each country should take. So back to the global agenda, the Immunization Agenda 2030 places priority on reaching those that are left behind. So, and to ensure that all children receive all vaccines. And it frames community health workers as the pillar of a strong and equitable immunization response. This is why I believe at CHIC that community health workers should be the key agents for change in the Gavi 6.0 strategy in order to support the immunization strategy 2030. And now let me conclude with a personal observation. So we know that vaccines are one of the best investments in health. We know that the governments can generate up to $10 return for every dollar invested into community health care. How long do we honestly need to discuss about investing in community health care? So at D3, we believe this so much that we actually introduced the under-immunized children rate as a measurement, one of the measurements of our performance. Now it's my privilege to introduce Maureen Wauda, a community health worker supported by Lwala in Kenya, who will share with us her direct experience of providing immunization for children who need it the most and delivering healthcare to those to zero-dose children or under-vaccinated communities. Thank you so much. Have a great day, and Maureen.
Okay, thank you. I'm Maureen Akomo Wauda, a lead community health promoter working in Awendo Sub-County, Migori County, in Kenya, under Ministry of Health, and being supported by Lwala Community Alliance. First and foremost, I would like to acknowledge the presence of all the community health promoters in this hall. These people play a vital role in our communities. And I have a pleasure that I represent 100,000 community health promoters in Kenya, and also 1,000 or 1 million more globally. We as a community health workers, we are the link between the community and the facility. Nothing for us without us in that community. So I have a story to tell about a little child that I came to know before I became a community health worker. When the mother was pregnant, she became fond of me. And some people said that her pregnancy loved me. So Jen, I'll call her Jen, her family didn't prefer, they believed in a certain religion that never preferred taking their household, their families to seek health services at the facility. So when Jen got delivered, she had a home delivery. So she named her daughter Maureen. I was honored to hear so. But a few months later, baby Maureen became sick. And the mother took a lot of time before taking her to the health facility because they doesn't believe taking their children to the to seek health services at the facility will help. So baby Maureen passed on and later found that she died of a vaccine preventable disease. So at the community level, we play a great role. And when I gave birth to my babies, I ensured that all my children get immunized and get fully immunized at the health facilities. So you can see, as per now, I'm a community health worker. We do encourage or we do mobilize and educate the community on the importance and the benefits of taking their children, all the under 5 children, to get fully immunized at the health facilities. At the community, as I said before, we play a very critical role. And if we are not skilled, we'll not be able to give the right information to the community concerning vaccines. If we are not digitized, like in Kenya, I'm pleased to say that we are using a Kenya CHWs app that normally help us to do household registration and register these household members as our patients at the community. So we are able to monitor their health and also to ensure that their immunization are well scheduled. We also need to be motivated and supervised. This will ensure that during our outreaches or inreaches, remember we don't work alone in that community. We work with the healthcare providers. So this will build a trust between the community and the facility to ensure that we promote the uptake of vaccines, and also the coverage of vaccines will be good with that in that community. I would like to say that every member or every person in this room has an important role to play to ensure that we ensure that all the children under 5s or the health status of our community is good. So it's not only for me, for my family, but globally. Thank you.
Thank you so much, Maureen, and thank you, Riccardo. And welcome, everybody, to the panel portion of today's event. We're so excited to have all of you here today at the Impact Hub. And today's panel will really be looking at the important question that Riccardo and Maureen have set before us today, which is effectively how can Gavi's 6th strategy reach zero dose and unvaccinated children, and what might be the role of investing in community health workers to accelerate progress towards that goal. So I'm really thrilled to be here. My name is Madeleine Ballard. I'm CEO of Community Health Impact Coalition, as Riccardo said, a global movement making professional community health workers the norm by changing guidelines, funding, and policy. We are all your hosts today. I'd love for all the community health workers in the room to stand up. As Maureen said, there are many, so let's give them a round of applause. You too, you too. We have our brothers and sisters from Kenya, from South Sudan, and we welcome, we hope you'll all take the time to say hello as we conclude the event. Joining me on stage today is a diverse lineup of speakers representing really the breadth and depth of engagement with Gavi on its efforts to drive towards vaccine equity and really on the priority setting for Gavi's 6th strategy. So I'd like to actually welcome back to the stage Ms. Maureen Wauda, community health worker extraordinaire. Please give her a round of applause. Come on over here. Thank you. I'd also like to welcome to the stage Dr. Richard Kibanda, the head of health promotion and community health at the Ministry of Health of Uganda. If you could please take a seat. We also have Mr. Alex Jonquières, who is the Gavi's head of health system strengthening, the team which is really where Gavi is setting its human resources for health priorities. So please join us. You can, wherever you want to take a seat too. We'd also like to welcome Dr. Chen Mabuchi, who leads Gavi's head of resilient health and sustainable systems. Please get comfy. I'm not finished, and pandemic preparedness and response, and he's on the technical advisory group working with Gavi's health system strengthening team on Gavi's 6th strategy. So we can give another round of applause for that. A man wearing many hats. And finally, I'd like to welcome to the stage Miss Emily Bancroft, who is president of VillageReach, an organization that has actually been the longest standing expanded partner for Gavi and has supported immunization efforts in a number of countries around the world and is actually on a member of Gavi's CSO, civil society organization constituency. Miss Emily Bancroft. So as you can see, we have on stage with us today politics, the providers, and the payers of care. So it's really quite a wonderful cross-section of the ecosystem, thinking about these issues, working on these issues together in partnership. And we're very excited to, over the course of the next hour, dive into, again, the opportunity we have before us today, which is how CHWs can drive comprehensive and responsive primary healthcare under Gavi 6 in order to reach the unreached for immunization. So our panel today is going to unfold in 3 parts. The first part will just highlight some of the community level gaps affecting zero-dose and under-vaccinated children, particularly in the wake of COVID-19. Next, we'll define the role of community health workers in promoting immunization equity, both by driving demand and coverage. And then finally, we'll identify opportunities for Gavi to support countries to develop and scale last-mile immunization delivery under its next, and we hope most successful strategy yet. We may or may not have some time at the end for questions, so please note those down as you go. And let's kick it off by hearing from our colleague from Uganda. We'd love to understand, again, some of the gaps that we see in the delivery of immunization. We know that Uganda has made significant progress, Dr. Kibanda, in its immunization program. It's increased the number of fully vaccinated children even during the pandemic, which is really an accomplishment I think we can recognize. And now I understand the government has for its goal to continue to reduce the zero dose rate, which is at 3%, by half over the next 3 years. And I'm wondering, could you elaborate on your plans to expand last mile immunization in Uganda and maybe share your priorities and some of the gaps that you've seen?
Thank you. Sharing Uganda's experience and, of course, depicting on our success, more so during the COVID-19 pandemic. I would say briefly that our strength was more working with partners, because if you recall very well, partner coordination and engagement has always been a big challenge in developing countries. And in our country, it's one of the key areas that we did emphasize and ensure that partners align with the government priorities. So they more or less implementing one plan for the country during COVID-19. So that gave us an opportunity to be able to have success stories in terms of COVID-19 coverage, but of course also for routine. So similarly, during this time, we have also been able to develop a 5-year implementation plan, drawing lessons from the COVID-19 vaccination, with a lot of emphasis on stakeholder engagements, and of course also aligning government priorities by working with partners. The country is also in high gears to ensure that we do a lot of data-driven, innovative approaches at community level to ensure that our interventions targeting different communities are driven by data. But what is also interesting is that as a country, we are in high gears for scale-up of well-trained, equipped, remunerated, and supervised community health workers. We do have the volunteers who have been doing a good job at the village level. But as a country, we have also embarked on a paid-up cadre, which is based at a slightly higher level. And we have so far covered 10% of the districts. And I would think that our investments for last mile are skewed towards that, ensuring that in the areas where we need to see results, these districts are prioritized to ensure that we identify, we train, we engage, and ensure that we deploy the paid-up cadres. The other key component which we have also been able to appreciate is that many times some of the community interventions, we miss the behavioral health component. So the behavioral health research is one of the priorities that we are going to undertake within the 5 years to ensure that we understand more communities, especially where we have some pockets of resistance. We don't want to engage from an informed point of view. So I think that those are very, very critical areas. Lastly, government took a decision to apportion 30% of its resources, 30% of the primary health care resources to be skewed towards health promotion, prevention, hygiene, and sanitation. And we hope that, whereas we are getting a lot of support from Gavi, but if you think about sustainability, we hope that the government taking a decision of apportioning part of PHC resources will enable sustain some of our community interventions. Thank you.
Fantastic. Thank you, Dr. Kibanda. We don't have to clap after every response, but we do appreciate the wonderful progress being made in Uganda and some of the lessons learned that you're already incorporating into your next steps. I wonder, Maureen, you mentioned already in your remarks some of the barriers that you face in your work, but I'm curious, what are some of the biggest difficulties you see amongst your patients in terms of ensuring full vaccination in Kenya?
Okay, thank you. In vaccination, community health workers have a big role to play because they ensure that all the children under 5s are fully immunized. Even though we face some factors that are affecting immunization, these factors are, 1, lack of awareness and information, whereby you find that some households doesn't know the importance of getting their children to be immunized. So as community health workers, we ensure that we educate and give the right informations to these caregivers to ensure that their children are fully immunized. Secondly, we have accessibility and transportation, whereby you find that some households are far away from the health facilities, and also majorly during the rainy seasons, the roads are not accessible. So as community health workers, during our household visitation, we ensure that we put a reminder to these households to ensure that the routine uptake of the vaccine is taken for this child not to be a defaulter. Thirdly, you have cultural and religious factors. This is a major problem because, like I said in the story before, there are some households or caregivers that doesn't prefer taking their people to seek health medical services at the facility. So it's our duty, it's our role as a community health workers to ensure that we sensitize these households and we advocate for them so that these children are fully immunized. Remember, the community, they see me as a doctor within that community. And also they see me as a skilled or trained doctor within that community, so that I could give the right information for them to access medical services or immunization services at the facility. And that's why also I say that we work closely with healthcare providers to ensure that the vaccine uptake or the coverage of the vaccines within my community, but not only within my community, but globally is good. Thank you.
Amen to that. Thank you. Monsieur de Jonquières, Alex, I'd love to hear more about Gavi's approach to supporting some of these last mile immunization programs that Maureen's working in. Evidently, we're just coming out of a pandemic, so despite strong efforts, we're seeing that the zero dose and under-vaccinated rates of children currently are below targets, but we have a new opportunity here. And I'm wondering, what are some of the key lessons learned about immunization equity, including the role of community health workers in facing this challenge, and how are these lessons being reflected in the preparations for the CHIC strategy?
Thank you, Madeleine, and thank you for the event and for inviting us to join, and for the focus on immunization, which is very timely, as you talked about, because we are in the process of finalizing our Gavi 6.0 strategy. Maybe just to start with the big picture, because I think we are coming out of a pandemic, as you say, where there was significant backsliding in routine immunization, and I think sometimes we forget the progress that was being made before the pandemic. Countries in the first 4 years of our Gavi 4.0 strategy, so 2015 to 2019, reduced the number of zero-dose children in their countries by almost a quarter. So that was a very significant reduction in just 4 years, and we were on the right trajectory. Now, with the pandemic, there was significant backsliding, and we went back to before pre-2015 levels, and we are still in a place of recovery. So we have a lot more to do and a lot more work to do, but I think it's important to acknowledge that we do have some of the answers. That being said, as we came into our current strategy, we did recognize there were some things that hadn't worked so well historically, or at least where Gavi support and Gavi funding hadn't been as well targeted as we would like. And a few of the things that we really wanted to focus on with countries was firstly getting much more granular on the identification of who are these communities and why are they missed. I think historically immunization has tended to be quite sort of top-down and essentially one size fits all. And what we recognized is that the zero-dose challenge, and I think Maureen spoke to this really kind of compellingly, is inherently a local challenge. And to solve an inherently local challenge, you need really good understanding of who are the communities you're missing and why are they being missed. And that takes a much greater level of analysis and planning than had been the case historically. Once you know who they are and why they're missed, I think a lot of the barriers are actually barriers as an immunization community we hadn't focused on so much. I think we tended to have an assumption that you provide the services and people will arrive and get their children vaccinated. And again, I think both Maureen and our colleague from Uganda spoke very compellingly to the fact that's a pretty simplistic assumption. Maybe 80% of parents will do that, but there's a significant portion who won't, either because they don't know about the service, because they have concerns, fears, or the religious and cultural beliefs. There are gender-related barriers. And those take a very different type of engagement and a very different type of strategy to ensure that those people, those parents, actually do get their children immunized. And so a much greater focus on tailoring service delivery, overcoming those gender-related barriers, ensuring that we had much more sort of sophisticated demand and behaviorally informed strategies. And then the other two key shifts we focused on were trying to scale up some of the digital tools that are essential to enable all of those things, and strengthening our partnerships with civil society and community organizations, which were an area which we recognized we needed to do more. The good news is I think we've seen in a lot of the planning, last year was a record year for Gavi in terms of programming by a long way. 40 of our 57 countries applied for new grants related to zero dose because so much planning was delayed during the pandemic. And many countries were starting to really kind of emphasize and focus on those areas. So I think we have a strong foundation now, and the key is really kind of making sure that implementation follows. You asked about sort of lessons learned, and I've talked about them a little bit already, but maybe just to highlight three. I think one is the zero dose challenge and is inherently local. This is about finding the communities who are systematically missed, not just by immunization, but typically by the health system. And there's a reason they're missed still after all these years in health, of investment in health and health systems. And there isn't a one-size-fits-all solution. There was some research done early in sort of the work on zero dose to try and figure out who are these communities and where are they, and can we say they're all in these types of settings? And what that research found was that about half of them were in either remote rural settings, urban settings, or fragile settings. But about half weren't. They were sort of all over the place, and that I think speaks to how tailored and localized our approaches need to be. And of course, that is why community health workers become so important, because they understand their communities better than anyone, and they are that bridge to those communities. That links to my second lesson. I think as a alliance, we had not been very focused actually on how we can best invest in health workforce and community health workforce generally. We do invest significantly in community health workforce. We have investments in many countries, including in Uganda, in the community health workforce, but we hadn't really had to approach it systematically, partly because our funding is significant, but always only a portion of what countries need. But partly I think it was just a gap in our toolkit. So we are now working to really try and develop a much more deliberate strategy, working with colleagues in the Global Fund and elsewhere towards how we invest in the health workforce. And I think the third lesson is that this kind of change does require real political commitment to see through. Again, there are reasons these communities are missed, and there are really positive examples like Uganda, where there's that real political drive and commitment and ownership, and there are others where it's harder to make some of the changes, and we really need to keep the kind of importance of zero dose on the agenda and on the radar, and keep not just advocating for why these communities are important, but also some of the changes that are sometimes painful changes that are needed to reach them.
Thank you so much. I'd like to, building on some of those challenges that you mentioned, throw a wild card into today's event and actually recognize with us we have the Honorable Mdomi Njuki from the chair of the Health Committee at the Council of Governors in Kenya, who's actually, Kenya's in the midst of making a pretty profound transformation in terms of how they're delivering community health services, moving from volunteers to professional community health workers, or community health promoters, as they're known in Kenya. And I wonder if I might just direct one question to you, Honorable Njuki, and that's what as you're making this transition, what financing gaps do you see in immunization efforts at the last mile in the community in particular? What's on your mind as the Council of Governors is overseeing this massive transformation?
Thank you very much. It's really a pleasure to be here and to listen to what Gavi and our partners have to say about promotion of immunization in third world countries, especially where we have gaps in financing of health. And in particular, we appreciate the fact that the community health promoters have come to really bridge the gap that we have in that financing. Why do I say this? Because for a very long time, without the community health promoters, we have been spending a lot of money at curative level, which is very expensive, because we ignored the basic primary norms of health, which can be taken care of by just behavior change and timely reporting to the facilities, and that is where they come to bridge the gap. And especially in vaccination, I appreciate my community health worker, Maureen, because she has given the story as it is, and she actually enumerated exactly what the community health workers are missing or they're going through in terms of the gaps that are there. When it comes to vaccination, I do agree that the availability is not most of the times a problem, but the timely availability of the same to the community. When you look at most of the rural community, we have gaps in power and getting the renewable energy, in terms of solar, in terms of sometimes fridges that are charged with maybe in local shopping centers and with batteries and move for some time. So we have issues where the vaccines that get to the community sometime in the facilities may be expired vaccination. So when we fund vaccination, we should also ensure that we also fund the safety and delivery so that we do not end up giving the vaccine that are expired. In terms of contact tracing, which is very critical for mothers from prenatal to antenatal and even up to when the children are 5 years of age. The empowerment of community health promoters in terms of reporting and having the tools to report to the local facility so that a mother does not end up getting one vaccine and then when probably the community health promoters has moved to a mission on rescue or something else, eventually they miss on the next one. So there should be continuous training that empowers the community to know, not just that they have to listen to community promoters, but they have also take up the responsibility and know why their children have to be vaccinated. Policy issues, as I finish. For a long time, Kenya has been operating without a policy and community health promoters. Initially, we used to call them community health volunteers, because when you put W in terms of community health workers, the unions usually rein in on you in terms of employment terms for these people. And what they are paid is usually stipend, not a salary. And therefore, they start demanding for pension, they start demanding for all the other issues that come with real employment. And therefore, we tweaked from community health workers to promoters, and we give them a stipend that is slightly high that can enable them to move around, and they have their own tools they can be able to move with. And that policy enabled us now to have a structured and recognition of that field as a professional field, just like the others. And I can tell you as I finish, they play a bigger role in promotive and preventive, even more than our facilities. Because by the time you get to the facilities, you are dealing with curative level, which in our calculation, $1 spent on promoting community health promoters and preventive saves about 9 in curative level, which is very important for us in third world countries. Thank you.
Thank you, Honorable Njuki. We just thought, as Mr. Jonquières was talking about political commitment, that we would highlight the power of political commitment and really the fact that so many of these issues that we're speaking about, we speak about them for years and years and years, and yet a transformation can occur in just one term. This can actually be the legacy project of just one Minister of Health, of just one president. And so we're really excited about the possibility for rapid transformation across the continent and beyond. Shun, Dr. Mabuchi, we've heard about a number of challenges, local all the way to structural from the panel. Is there anything that you feel like has been missed? How would you kind of summarize the challenges facing zero-dose and unvaccinated children from your point of view at the Global Fund?
Thank you. So yeah, I probably cannot summarize the multiple issues well, but first of all, really thank you for having me here. And I've been joining a lot of the WHA side event, but this is probably the most innovative in setting and having a community health workers, yeah, and the leading discussion and also other participants. So really appreciate it. And this setting really help us anchor the discussion on what's needed in country, how different mechanisms can support the community health workers to serve the community in the most effective way. So really appreciate it. So probably Alex laid out the key issues discussed at Gavi, and then all the discussion around how the community health workers facing challenges in supply, transportation, and demand, etc., that Maureen and others laid out is really a key issue. But just probably two things I would add related to Gavi. One is the discussion is very nicely focused on how Gavi can address the zero-dose community in a way that really support the country's primary healthcare system and country's community health system, rather than really being in a vertical immunization-focused approach. So how can we do it is a big issue that's been discussed. And related to it is Gavi has, of course, significant funding, but the health system's funding is not that significant. So how can Gavi leverage other investments from the Global Fund, the World Bank, and others, and also the country's domestic funding to really help the country's system serve better for immunization and the zero-dose community? So those are, I think, really important topics that Gavi has been really thinking through. And zero-dose is not the problem of immunization. It is actually a problem of all the health services. Those communities are the communities that requires health services comprehensively the most. So really, we need to think about those community, other community, rather than the target for the immunization. So that's how we kind of imagine our services and the support, including the Global Fund support, in that more integrated way is a big challenge we are discussing. Thanks.
Thank you. That's actually a wonderful transition, Shun, to maybe the second part of our discussion, which is, okay, how do we begin to solve some of these issues as Gavi 5 comes to a close in 2025, and we have, as you say, Gavi 6 kind of on the horizon. There is really an opportunity to tackle some of these key challenges with political will, with new innovative investments and partnerships. And so I think that's like where we'd like to take the discussion next. We heard earlier that community health workers serve, in many cases, not in all, but in many cases, as the first and often only contact between zero and missed dose children, whether they're in rural areas, whether they're in urban areas, or even in fragile zones. And so I'd like to start by exploring the possibilities for action, particularly the role of community health workers in promoting immunization equity, both in driving demand and coverage. Emily, VillageReach recently published a rapid review on community health workers as vaccinators, so not just promoters, but actually those who provide intramuscular injections. Can you share how some of your community level work in Malawi addresses some of the gaps that we've discussed so far, and how it's informed by the review's findings?
Sure, absolutely. So I think it's helpful to frame a little bit the different roles that community health workers do play, as Madeleine's saying. And this is part of what we looked at in this rapid review, was saying, okay, what's that continuum that community health workers play? So there are about 20 countries of the 75 that we looked at who have, at one time or another, had community health workers who have actually administered vaccines. About 18 of those through injections and 2 where it was only oral. So it's a small number of countries. And I think even more important is, of those 20, less than half of those are actually operating at scale. So we looked at anyone that had ever done a pilot, had ever done something in a single district, something testing this model. But there are very few countries that are really doing this regularly and routinely at scale. Malawi is one of those, and that's a place that VillageReach has worked for a number of years. And what we see is there's a real opportunity here. We know we have a shortage of healthcare workers. We know, as all of the panelists talked about earlier, that community health workers are uniquely positioned to identify that, as we often talk about in the immunization space, that fifth child, the 20%, it's a little less than 20% now, but it's a persistent 20%, at least as long as I've been working in the immunization space. We've been talking about that fifth child. And community health workers are really uniquely positioned to understand, as Alex said, this isn't, there's not a single reason. It's really, there are very many local reasons why, and community health workers are well positioned to find those. And so if you can actually equip community health workers with the skills, the knowledge, the supplies, and of course, the remuneration that they deserve, then you can utilize that as an extension of the workforce to go out and actually reach and vaccinate children. And you see that happening in places like Malawi, Ethiopia, a number of other places where it is happening. But it's also important to say that there's another level in that continuum, which is also incredibly effective that we've seen. And that's where, and Maureen talked about this a bit, where community health workers, maybe they're not giving injections, but they have a very clear and active role in recruiting, discussing with families the power of vaccination, addressing specific questions that families may have about vaccinations, understanding the vaccination schedule, understanding, in more detail what a really strong immunization program looks like, and then linking those families to mobile or clinic-based services. And that's incredibly powerful. I just saw some early research coming out of Mali, it hasn't been published yet, that showed an incredible graph using the digital tools that Mali's using to track who's getting immunized, where just utilizing professionalized community health workers as that conduit and really bringing them into the immunization programs, you could see this incredible decrease in the number of zero-dose children because they were reaching them. They knew who they were reaching them, they were bringing them in for services. So what we need to enable here is, one, we'd love to see more countries moving towards using community health workers as vaccinators. And I think there are great examples out there in countries that other countries can learn from. But secondly, we'd like to see that more formalized engagement of the community health workforce in immunization programs. And I think those two things create a huge opportunity right now with Gavi 6.0, and with this increased focus on un- and under-immunized children to really lean into that work. But we have to be supporting community health workers with the training, with the tools, with the remuneration that they need, and that policy environment that really clarifies what their role is in this work.
Thank you, Emily. Shun, reaching the unreached is a big part of obviously what you do at Global Fund, and over the last year, you've allocated about $583 million to CHWs in 2023, with plans to increase this to $1 billion. How did these investments strengthen your core mandate of combating HIV, TB, and malaria, and what lessons might we apply to the immunization response?
Thank you. So yes, as Maureen said, we are really scaling up the community level investment and acknowledging that really the services for HIV and TB and malaria is really significantly supported by the community. And the one important lesson or the direction we've been thinking about is from efficiency, sustainability, and also country ownership point of view, doing it vertically, like a TB community health workers, HIV community health workers, doesn't really work. So we need to really support countries to build the national community health program and the primary healthcare program, and then really support that to serve for HIV, TB, and malaria in an integrated way. And so how we can do it is probably two things. One is we really need to lean into the systems building for the national health program and supporting the community health workers to make sure they are well paid, regularized, well paid, equipped with transportation, and supervised and protected. So it's really a systems building related to the legal framework, financing, and then also the all the support system. So we think of it as a systems maturity, and we try to think of it in an integrated way, and also measure that in an integrated way, and also think about supporting the countries, the baby steps, or moving toward more sustained financing mechanism. So how we do it depends on country's context, but it's one big focus of the Global Fund investment now. And then the second is, as we think about the HIV, TB, and malaria needs and the community health workers, of course, community health workers cannot do everything, right? There's depending on the countries, there's a policy issues for community health workers to serve some extent for malaria, some extent for HIV, but not all of the services. So working with the country to define what community health workers will do and can do, will not do, and then how we supplement it in different ways. For example, for HIV, of course, there's a highly stigmatized key vulnerable populations that not always the general community health workers can serve the most appropriate way. So we need to supplement with the community-based organization, community-led organization that really coming from that particular population group. And that's also probably related to immunization, because those groups are generally most stigmatized, not just for HIV, but for broader health services. And then, for example, for TB, TB concentrates a lot in urban area. If we do the cookie cutter community health program focused on rural population, the TB communities, TB population in the urban slum can be missed out. So how can we really support the community health systems to be able to serve for really a key disease need in an integrated way is also a big lesson learned, and how we want to improve our support. Thanks.
Thank you. In addition to the three diseases, I think there might be some lessons to draw also, as Dr. Kibanda said, from the pandemic, the recent pandemic. An analysis of household surveys recently published in Liberia showed that community health workers integrated into the National Professional Community Health Worker Program had higher COVID vaccine acceptance than those without. Maureen, how have you seen CHWs help close the immunization trust gap that Emily described?
Okay, thank you. As a community health workers, as I said before, we play a very important role within our community. And when it comes to in my community, when it comes to my community, they see us, and they see us that as, pardon, just a minute. In our community, we play a very important role within our community, and our community members, they rely on us as doctors within that community to ensure that we give them the right health services in that community. So our professionalization is also very much important, because when we are professionalized, we'll have those skills to at least give the right information to the community. And then when it comes to vaccination, professionalization is also important. Two, we also need to be trained. When we are trained, we are able to give the right information to the community. We need to be digitalized. Like I said before, this will help us fast track our clients or fast track these households to get immunization scheduled at the right time through digitalization. Because we find that in our HIS app, we have the household registers, whereby we have the tracking system that leads at that this child needs to go to the facility to get vaccinated. Fourthly, we need to be supervised and salaried and paid. So when all these are done at the community level, we are able to deliver our services at the community. We also need to be, I don't know what they say, supplied. We need to be supplied, like in Kenya, we have the equipments at least to assess the households on various diseases, and also to ensure that the under 5 children are taken to the health facility. And as I said before, we work with the healthcare providers at the community level and also at the facility level during our outreaches and also during our monthly reviews, whereby we ensure that our work are always on toes. So in vaccination, if all these are not done, we'll not be able to have the increase or the uptake of vaccine, the vaccine uptake to grow, or the vaccine uptake will not grow if all these are not done to the community health workers. So I'm just appealing for the donors and the partners and also the national governments that are here, that let's see a community health worker as an important person within that community. And not only within that community, but I say this globally. Thank you.
Thank you, Maureen. So, Emily, Maureen just made a strong appeal, I think, for professionalization, for salaries, skills, supervision, supplies. We know that professional CHWs are still in the minority, but much like CHWs providing vaccination, they do exist in tens of countries, in almost 40 countries at this point. During the pandemic, as Dr. Kibanda said, and as Alex also said, we saw many countries struggle to sustain immunization progress, in lining with broader disruptions to care really across the board. However, there were exceptions to that. Can you elaborate on some of the surprising findings our coalition discovered regarding continuity of care during the pandemic and the presence of professional CHWs like Maureen described?
Yeah, absolutely. And I mean, just to start with, and I know Shun at the Global Fund shares this as well, you know, we fundamentally believe that if you build a strong primary healthcare system that reaches the hardest to reach communities every day, that system will respond better to shocks and stresses and strains. And this is exactly what we saw during the pandemic. So across the coalition, as Madeleine said, we pooled the research that coalition members did during the pandemic to look at continuity of care. And what we found was that the presence of the adequately supported, professionalized community health workers that Maureen so eloquently talked about, that we did not see the same backsliding in countries that had that community health workforce. If they were protected, and we at the coalition did a lot of work on making sure that community health workers had the PPE and protective equipment that they needed to continue working during the pandemic, but where they continued working and where they had that professionalized, paid, supported role within the health system, we saw across the coalition much less backsliding. And, so they were able to maintain speed, they were able to maintain coverage during that period. But there's actually another study I want to talk about, Madeleine, because I think it's very powerful. Again, coming out of Mali.
When you give people microphones, all of a sudden they're just...
I mean, this one I think changes the whole paradigm for how we think about what we expect during emergencies. So in Mali, the Ministry of Health of Mali and one of our partners, Musso, who I don't think is here today in the audience, but another member of the coalition, they published some research in November. If you haven't seen it, you should look up this study. So what they were trying to study when they started this research was, what is the impact of professionalized, supported community health workers linked to strong primary healthcare centers doing home visits? What is the impact of that on under 5 mortality? They start this study, and then war breaks out in Mali. They continue the study through that period of disruption, significant conflict in Mali. They cut under 5 mortality by 2/3 during conflict. So it was supported community health workers linked to strong primary healthcare centers, committed to continue working during a conflict, working in an enabling environment that allowed them to continue their work and supported them to continue that work. And they did proactive home visits during that conflict, and they cut child under 5 mortality by 2/3. So from 148 for every 1,000 live births to 55 for every 1,000 live births. I have nothing to do with this, but I mean, it is like, it deserves, and I think for me, this changes the whole paradigm of what we should expect, right? And what we know can happen if you invest at the right levels. And so the solution is right here. We know the solution. We now have evidence from a number of different places that it works. And it's just a question now of how do we make this the practice?
Those are two great studies, and because both of them challenge, I think, the dominant paradigm, which is that in pandemics people die and in conflict zones people die. And I think what we've seen is actually, if we set up resilient health systems, we can continue to make progress in pandemics. We can continue to make progress in conflict zones, and that actually should be our standard. So let's hold ourselves to a higher standard, because there's no longer a question about whether it can be done, it's just how fast and where. Alex, it's clear that global health initiatives have been thinking about these various challenges, pandemics, conflict zones. You mentioned this survey of under-vaccinated and unvaccinated children and the work that you've done. The recent Lusaka agenda provides, I think, a platform for some of the coordinated action that these results demand. I'm wondering, how does the newly launched partnership between Global Fund and Gavi embody some of the 5 shifts, strengthening health systems for primary care, coordinated approaches to health system strengthening, that Lusaka agenda calls for?
Thank you. And I think maybe just to start by saying, the Lusaka agenda is not the first go at solving this problem. Hopefully it will be the most successful.
Amen to that.
I think it's something,
You're in the driver's seat, Alex.
Well, we're all in the driver's seat, actually. And the reason I say that is because there is a bit of an inherent tension in some of the discourse. And even if, I'd be a bit provocative coming into this event, one of the questions I had to be asked was, how are we going to invest more in community health workforce? And at the same time, the question of the Lusaka agenda is, how do we align behind nationally led plans? We can't do both those things. Either government's in the driver's seat and we are supporting them with their plans, or we're making decisions from Geneva and saying, well, this is what we're going to fix. And I think we have to acknowledge that tension. And it's not to say, it's real and we have to manage it. But I think it's an important one to acknowledge, because the answer is not going to be one end of the spectrum or the other. It's going to be, how do we get that balance right? And I think on the community health workforce side, it means we're not, from the Gavi side, going to say we're going to invest X in community health workforce, because that would require us to say across 57 countries we think X is the right amount of money. What it does mean is that we need to make sure we have the right tools, the right advocacy, the right discussions with governments as they are programming our funding to say, this is an important area, this is a priority, and these are some of the things that we would like, we would encourage you to use the funding to support. But I think that sort of nuance is important, because what it means also, as Shun talked about, is the critical importance of national plans, of strong national plans, to align behind. And we know some countries have really, really strong plans that that are, ready to go, and where basically we just need to get our houses in order to make sure we're aligned behind them. And others don't. And where that doesn't exist, the question is, how do we fill that gap? And that's true, I think, in the community health space as much as any. To come back to the question on the Lusaka agenda, so I think there are a number of the shifts that were identified in the Lusaka agenda which are already core to the Gavi model. And so, for example, the kind of catalytic role around domestic resource mobilization, the Gavi co-financing and transition model, I think is a very important example of how that can work. The kind of focus on strengthening health systems for PHC, half of our investment in health systems goes into the zero dose agenda, which is sort of core of focusing on equity and primary healthcare. But there's a number of things we want to do differently and want to do better as we go into the Lusaka agenda. One is, I think, actually trying to move to program much more based on national strategies. We want to move towards using a national strategy as the basis of programming. I say a national strategy because originally we were going to say the national immunization strategy. The risk of the national immunization strategy is in some countries that may actually not be the basis for a really well-designed sort of integrated primary healthcare strengthening approach. But either national immunization strategy or another document becomes the basis of our programming rather than having a separate process just for Gavi. The second is to massively simplify our grant architecture, so it's much easier for countries to use the funding we have in to support their priorities, and we don't have nearly as many kind of different grant modalities with different rules, different timing, etc. And the third, I think, is the focus on how do we collaborate better and how do we ensure that we are aligning both better to national plans outside immunization and with other partners. And we are an alliance, and that means we have to change both how we work among ourselves and externally. So, it means immunization colleagues in all the agencies, city and country level, need to think differently. The truth is, I think immunization people tend to be, it's a strong community with strong views on how things should be done. Sometimes that leads to thinking in quite a verticalized way, and that means every agency within our alliance is going to have to think differently. And it means we need to also think differently, including how we partner with others. And so part of that is the work you alluded to, which is with the Global Fund and now with the GFF, really looking at how do we strengthen and align better what we do. And we've got three key priorities there. One is around malaria. With the malaria vaccine becoming available, how do we really work with countries in an integrated way on the malaria control programs? The second is health system strengthening, and Shun and I are in regular discussion around that, and how do we kind of align as much as possible our approaches, our processes, our dialogues with countries, and build on each other's comparative strengths. The Global Fund is probably significantly ahead of us in this particular field in terms of investments in community health workforce. So how do we build on that rather than doing something completely new? And then the third is country engagement, and really a plan to identify a set of pathfinder countries where we can try working very differently. If we try doing everything everywhere all at once, we probably will not succeed, or not very quickly. We want to try and prove this can work differently in 5, 6, 7 countries, and then learn from that and scale from there. So that's sort of the core of it. I think the last thing I'll just say is, as we do this, Shun spoke to this, and I think it's something that we talk about a lot, but we haven't yet really fully captured the opportunity for, which is how do we use zero dose as a common priority? I think still too many people see it as an immunization priority. These children live in communities which are systematically deprived of healthcare services. We know zero-dose children are twice as, or their mothers are, for example, twice as likely not to have had access to skilled birth attendants or antenatal care. They're much more likely to be malnourished. They're much likely to be below the poverty line. These are just systematically marginalized communities, and we all ought to make them our first priority, because if we're serious about universal health coverage, we don't reach them with even immunization, we're not going to reach all the lofty goals of the universal health coverage agenda.
Amen to that. Dr. Kibanda, how does that sound to you? Health system strengthening, expanded partnerships, in light of the challenges that you articulated and the plans that Uganda has at the beginning of this panel, what do you need from these partnerships to move forward?
From my perspective, I think there are three core areas of focus. And I think one will definitely be directed to CHIC. Let me start with you. Because definitely you'll find out that over 90% of the people who are here may be technical. They all appreciate the role of CHW in advancing the immunization agenda. But we know that in most countries, heads of governments have an upper hand in taking decisions on where investments or priorities for the country should be aligned. And this is where we need support. I also happen to be the chairperson of the Africa CDC, Continental Coordination Mechanism for Community Health. And I have made it very clear to the principals that we need high-level engagements with heads of states, because presidents of countries determine where resources go. And to many politicians, they would like to see health facilities because that's what makes news in communities. So many people don't understand the relevance of investing in health systems, and we believe more so in community health systems. And investments in community health workers has a big impact in building systems at that level. So my very first request to partners is that they need, as they provide resources to countries, countries should also be able to make commitments, more so in the line of sustainability. And what CHIC can do is to work closely with other principals to ensure that high-level engagements to countries take place. So the other component which I think that is very, very critical, it's good that we have Gavi here and Global Fund. From the Ugandan perspective, at least, we have received over $6 million US dollars to invest in training and equipping community health workers in our scale-up plan. But I would say that doesn't come cheaply, because many people who take decisions don't value investments in community health workers. In workshops, in conferences, and roundtable discussions, they praise the works of community health workers. When it comes to apportioning resources as an area of investment, they don't do it. So for me, as we expand our advocacy agenda, we want to see people who take decisions. They can ably identify investments in CHWs as one of core areas of focus. If Gavi, for example, says we are giving 100 millions to, say, Africa, or say to Asia, or say to any continent, let me even be specific. If you say you're giving 50 million to Uganda and say, out of 50 millions, we would like to see 10% or 20% of these resources skewed towards community health workers. So the plans that are coming from the countries, we're expecting 20% of the investments or priorities to be skewed towards this. This is the kind of direction that we're expecting. Sometimes our colleagues who are giving us resources, they are very rigid. Even when you say, these are our priorities, sometimes it is difficult for them to quickly say, okay, let us look through what countries are saying and let us allow them, because after all, we are giving them 50 million US dollars. Let them use their resources the way they think that the resources will be more impactful. So for me, at the global special agenda, as we try to advocate for CHW, we know the roles and responsibilities, we know the value. I think we need now to swing into action. As we receive resources, as we set out priorities, as we send in our requests, and also the responses from our key donors should be aligned in a manner that gives us space to be able to take decisions where we would like to see our priorities.
Thank you so much, Dr. Kibanda. So today we've outlined some of the barriers to reaching zero-dose children, and indeed just reaching everybody with healthcare, as Alex articulated. We've figured out what lessons we might learn from the 3 diseases, from the pandemic, from care delivery in difficult and fragile contexts. And we've ended with a call really for high-level engagement and to put our money where our mouth is. So to close on that note, I'd actually just like to invite our colleague, Dr. Nan Chen, to tell us how we can do both of those things together.
Awesome. Let's give a round of applause for our esteemed panelists. It's great to see so many familiar faces on the panel and in the audience today. Thank you for spending your time this morning with us. I have the incredibly difficult job of summarizing and closing us out on a few themes that I heard. You panelists and Riccardo and Maureen, you have all taken us on a journey in these last hour and a half. And I felt when I was listening, it was not just a technical journey of evidence and impact and innovation, it was emotional for me. It was a journey from despair to hope and action. Maureen, when you were sharing your story this morning of Jen and baby Maureen, a child death, a tragedy. A preventable death is an injustice. And what we are here for, you reminded us why we're here. We're here to turn injustice into action and eventually to justice. And when we heard the panelists this morning, I observed, it occurs to me that we know what to do. Payment, professionalization, getting supplies through the cold chain to last mile communities. We know what to do. When I hear Dr. Kibanda, you're talking about partner coordination. It's intuitive, right? I can't be invited to your house and then I tell you how to move your furniture, how to cook your food, how to wear your clothes, and expect you to greet me with a smile. We know what to do, and there's a long list of what to do, but we know what to do. What strikes me as the next piece of this, where, actually, let me just name a few things, because they're so exciting, right? Even the studies that you were mentioning, Emily, about the 2/3 reduction in under 5 mortality, the early studies, the studies that suggest that community health workers, as we have always known, are not only the bridges of trust to the communities, but in some cases are actually delivering the vaccines and delivering the medicines that are these promising practices that push the innovation. We know what to do. The question is, why is it so hard to do what we already know? I think what our job is going forward is to make the hard easy. For a patient like Jen, who is coming from a particular cultural background and society, how to make the choices that are hard to change, to say no to my family, that I'm actually going to change my behavior, to make that easier for her, to make it easier for community health workers like Maureen, or I see John, I think Aisha back there, to say, I can come to work every day and I'm not just pouring out my cup and emptying myself, but I'm being remunerated, I'm supported, and this is a career I can see for a long time. To make it easy for folks like Shun and Alex, before I came to this role, I led a health systems team. And they often felt like I was the sort of nerdy kid at the table talking about integration and cross-cutting coordination, and all the cool kids were talking about the facilities and the diseases that were getting all of the attention. How do we make your lives a little easier when you or your colleagues have to make hard decisions about funding architecture or where to allocate resources? How do we make Dr. Kibanda's life easier and make the choices that you're trying to advocate for, your Minister of Finance, to make it a little easier to allocate that budget line? Seems to me, we know what to do. This next period is how to make those hard choices for us and for others a little bit easier. And I'll just name a few themes and action points here, and we'll close out. What I heard across were three things: align and integrate, innovate, and then enable. I heard that we are, and if let's say hypothetically I were writing a new strategy for immunization over a couple of years, I would want to have a component that says align and integrate behind the country-led agendas. I know that at Africa Frontline First, we're working with Shun's team a lot on how do we take that commitment to alignment and turn it into practical tools for doing so, working with other donor partners and implementing partners. Align and integrate behind the country agenda in a systems approach, which may not be cool always, but it is the right path forward, and we have to make that easy. The one plan, one budget, one M&E approach that Dr. Kibanda was referencing earlier is a great place to start. Align and integrate. Second, innovate. And invest in innovations in immunizations. We heard a number of them today around how you might target zero-dose patients in a more detailed, localized, granular way. I think the work that you, Riccardo and Dietrich, are doing, particularly on digitization and data, can really accelerate that kind of targeted approach. The research that Emily noted on CHWs as vaccinators is pushing the boundaries of what we think is possible through this workforce. To innovate and invest in innovation. And lastly, enabling policies and politics. The innovations push what we think is possible. The policies and politics bound and guide what is permissible. And we need to close that gap a bit and make the possible with good evidence and data part of the everyday permissible in the policies that we are guiding, that countries are writing, and to match the CHW policies with the practices that we already know work. So I think those were kind of the big themes I heard: align and integrate, invest in innovation, and bring enabling politics and policies to the table. So with that, I thank you, panelists and contributors, everybody who came here this morning. Thank you to the Community Health Impact Coalition for convening us, guiding us today. And with that, I do see a hand up from my honorable Council of Governors representative. So I will pass the mic and allow you to close us out. Thank you so much.
Thank you. I just felt this nudge to ask a very hard question. It's not easy, and it's to Alex. Gavi has been doing a very good job in providing vaccines for our countries. Of course, there's what you donate and there's what we have to pay for. Now, Dr. Kibanda talked very well about decision makers. And sometimes decision makers change, regimes change. You may be in a country where the head of the government is very keen on maybe a program. Then change of regime, then before they settle down, there's a lag in between there where there's no really any push towards the same. So what happens when a country decides we are not going to prioritize paying for vaccines, yet children are being born every day, they need vaccines, and then Gavi says, we will not give you vaccines because you have not paid. You have to do something about this. So you give them vaccines after 5 years, but in that 5 years, polio is back and many others. So it is something that really needs to have a decision beyond those very few decision makers. It could be about 20 or less. Sometimes it could be a minister in the ministry. It could be a PS. The head of government may not be aware. And it's a very big problem back in Africa. Then secondly, yes, just one more. Maureen talked about the cultural and religious barriers. And he talked about a community who have religion that does not allow people to go to hospital. It's something we have to deal with in Africa. But the others that are global. the HPV vaccine uptake in Kenya has been extremely very slow. And it is attributed to a church I go to, and I don't have to mention which it is, that took a stand that we will not allow our girls to take the vaccine. And it's not a church that is only found in Africa, it's all over the world. Last I checked, where it is domiciled, the girls there take HPV, the vaccine. Why is it that now Global Fund, Gavi, cannot intervene and talk to the old chain? Because eventually our girls will keep on dying of a cancer that would have been prevented just because of a barrier, which does not have any scientific backup in exactly what they're talking about. It's just a concern. Thank you.
I'll do my best to do both questions justice in a brief amount of time. I think on your first question, maybe I'll start with an anecdote. Dr. Ngozi, who was the Gavi board chair, former Nigerian Minister of Finance, now runs an organization just down the road. But when she took over as Gavi board chair, I remember her saying, when I was Minister of Finance in Nigeria, no one explained to me I had to keep paying for vaccines. And I was really annoyed. You know, when I pay for a road, the road is built, and then I go on and I pay for something else. And I couldn't understand why the Minister of Health kept coming back and asking me for more money for vaccines. And I think that speaks a lot to the challenge. And I think the challenge is a very simple one. It's about dialogue and understanding and making sure that this is part of the budgeting process on an ongoing basis. And I actually think that's why the Gavi co-financing model is so important. Because every country, no matter how low its GNI per capita, pays something towards its vaccines. And what that means is there's a budget line. And that means it's part of the discussion every year, even with a new government. And that doesn't mean it's always easy. And it does require advocacy and it does require engagement, and especially as country share increases over time, that requires more and more support and push to make it happen. But I will say, we've never had a country stop paying their co-financing and us have to stop the vaccines. And I think it's a huge success, actually, and a huge tribute to the countries, but also to the fact the model does work. And it requires a difficult conversation every year, but that difficult conversation does result in actually typically countries co-financing. The only exceptions where we've made waivers are where there's really conflict or war, and it's genuinely a very kind of exceptional event where it's, you know, the country really has a very good reason why they can't pay. But political change, generally, we've managed to maintain that co-financing throughout, and I think it's something we can probably learn from as we think about other areas where maybe we could have a more of joint financing approach. Very briefly on your second question, I don't have the answer to everything on vaccine hesitancy, and digital 21st century communication tools have definitely made spillover much easier of vaccine hesitancy and misinformation from one society to another. But I think HPV does also speak to how we need to think really in a much more person-centric way about the messages we give. When we first introduced HPV, it was a vaccine to prevent human papillomavirus, a sexually transmitted disease. And we worked with the sexual and reproductive health community, and a lot of the misinformation linked to, well, this is about promoting promiscuity and underage girls having sex, and not about this is preventing cancer. And one of the reasons why I think vaccine hesitancy for a long time, and still probably to this day, has been lower in countries we work with than in some of the high-income countries, is because the diseases are still seen in people's daily lives. And so it's much easier, it's much harder to dismiss measles vaccine when you see children dying of measles. And I think if we can say the same thing of, look how many people in your community are dying of cancer that could have been prevented by a vaccine, it changes the dialogue. But I think as technical people, sometimes we forget exactly how we communicate it and how we link this to people's daily lives and experience is so important. And I think we're still we're still learning that lesson for HPV.
Okay, well, we thank you so much, everyone, for coming. We welcome you to direct any further questions to our panelists and community health worker colleagues over some drinks, and we'll see you throughout the week. And we'll be sending some materials your way. Notably, our colleague in the audience has written a piece just today in Devex on this very subject, so that'll be in your inbox later today. Thank you so much.